Thank you, Harshul, and it's again wonderful to be speaking at your course and to see a hall full of very interested people and people who are already on to TORIC IOL'S. So I think we need to learn from each other, and I think the first thing that we have not wished each other is Happy Valentine's Day. So multifocal toric IOL is not always a very Valentine's Day, but the need for a multifocal toric is something that we can never say no to, because in a person who wants a spectacle-free, a spectacle-independent vision, that patient is a demanding patient if he is not anything else. So for such a demanding patient, you need to know, and we all need to understand, that his vision has to be as good as possible. Not only that, the vision and the counseling, the pre-operative and the post-operative, all have to go hand in hand to have this patient as a happy patient after he has paid a huge amount of money, after he has gone in through the whole procedure. But what he desires, he needs to have. Therefore, if he desires more than we can give, his desires have to come down. So the spectacle independence after cataract surgery is actually on the move, and more people are demanding about it. And the multifocal did provide, and now we have the trifocal platform, which is a fantastic platform. I've had a very long honeymoon with the trifocal platform, have been using it for the last 4 to 5 years. And the ones that have come up now, the PanOptix platform, and we had the Visiol as well as the Zeiss platforms, which were also very good, though they came in the hydrophilic platform. So now we have the PanOptix, and the trifocality of the PanOptix is something that is really undoubtedly good. So the goals, of course, of the multifocal, and I'll take a quick raise of hands for this. All of us are using, how many of us are using multifocals regularly in our practices? So that's again a very good number. And I'm sure most of us are in that stage where we need to know when to use the toric multifocal or the trifocal, and when we can go ahead with just the multifocal or the trifocal. The goals, of course, are to maximize the image quality, the range of vision, which is so important, reducing the photic issues, and the functions of an independent pupil. And we have to, at one time, go beyond the multifocality and possibly go into pseudo accommodation. And this is all to meet the wants of the patient. Now, let us come to the scenario of the Indian patient, and is it really important for us in India to address this issue of a multifocality with a toric? Yes, it is, because this study, which is a recent publication, did show that nearly 30% have, of the Indian population, have 1 to 2 diopters of corneal astigmatism, of astigmatism. And therefore, this astigmatism is going to be a limiting factor, especially if you're going to do a toric multifocal IOL. So we used to discourage at one point of time, and we had to say no to many multifocal when we did not have the toric platform, but now we have these toric platforms, and the evolution of science and the evolution of these intraocular lenses have given us a lot. Therefore, this study I just wanted to show you, and this is a 2015 ACRS clinical survey in which they showed the physicians think that 0.75 or less is something that is acceptable if it is goes on to the multifocal IOL. So if you have something less than 1, then you can go ahead with a multifocal IOL without the toric platform. But even small amounts of astigmatism do impact the visual acuity, and therefore all our SIAs have come down to a great limit, and all of us are doing great surgeries, and therefore we need to concentrate even on the small amounts of astigmatism that there is. Now, Harshul showed a very nice video, and this is just to reinstate that same fact that how many of us are using the OVDs for implantation for intraocular lenses? Right. So, I want to reinstate this fact that we can implant the multifocal toric under the irrigation, and it is something very doable, something that not only saves time and the viscoelastic, but also the orientation of the toricity is well taken, is quick to come in, and once it comes in, then even with the hydration of the ports, it stays well in place. And it's something that we need to do, and obviously you can go ahead and do it in all your single piece lenses, but for the toric IOLs, this is a great advantage. And of course, Rajesh spoke about the posterior corneal astigmatism, and that is something that is incorporated as the Barrett toric algorithm in the online calculators. So the stability of the toric, again, is an important factor, and that has been always an issue, but numerous studies have shown that the toric IOLs are very, very stable. And I think one of our speakers is going to speak upon what happens if it changes, and then we'll carry on the discussion on that. But the stability is something that is important, and of course, most of the orientation stays as it is, and it is for a long term. Therefore, if you have promised multifocal toricity and if you have implanted that lens, and you have on the post-operative day, post-operative 10th day or the 15th day, a good and stable toric, then you can be quite sure that this is not going to change its toricity even in the long term. So what do the evidence-based medicine tells us? That what about the multifocal toric and the multifocal, the monofocal non-toric lenses? So it definitely showed that these were non-inferior. The multifocal toric IOLs were non-inferior to the multifocal non-toric IOLs, and to correct the uncorrected distance and the near visual acuities. Again, this study was important, and the evaluation of the rotation and the visual outcomes after implanting the monofocal, multifocal toric intraocular lenses at 1 month post-operatively, the uncorrected distance visual acuity was slightly more affected by the IOL rotation in the multifocal than in the multifocal toric. So these are things that are there very much in the literature. And again, the visual quality comparison between the multifocal toric intraocular lens and the monofocal toric intraocular lens, both corrected the, it gave distance and intermediate and near visual acuities were very good. But what is also a possibility, and that is something that we can think of, and that is if we have a low astigmatism, so can we do something else? Is there an alternative to this? Yes, there is. And the femtolaser technology has provided the alternative. So if a patient has astigmatism less than 1 diopter, we can safely go in for the multifocal or the trifocal IOL. If the astigmatism is between 1 and 1.5 diopters, then this femtolaser assisted LRI is something that you could really think of. And this definitely is a promising option. But of course, if it is greater than 1.5, then the LRIs do not work so well. And there you definitely need to go in for the toric platform. And even if you're doing a femtolaser, for these patients, it's wisest, and the astigmatism is above 2, it is wisest for these patients to undergo a toric lens with the femtolaser, and of course without the LRI. So as you can see that this PanOptix has been placed in the bag, and we are opening up the LRI there. And once the LRI is opened, it gives a good correction between 1 to 1.5. At times you can stretch it to 1.75 as well. So that's it, and let us take up discussions, and I'd be very happy to answer any questions that you would have. Thank you very much.